Bit of background on me as well. My name is Molly McCoy. As you see there, my company is McCoy Consulting. I am a CPO. I'm licensed in Washington State, and I've been in P&O for about 20 years. And what I do is, as an independent contractor for SPS, I help their customers learn how to document more appropriately so that reviewers and payers can understand what P&O is and why we do what we do. And prior to that, I was in clinic for a number of years in Kentucky and Indiana. I also worked for SPS for a number of years, and then I went back to clinic in Washington State. And after that, I taught lower extremity prosthetics at University of Washington. We'll do a quick overview of what we're going to cover in this webinar. This will be about an hour, maybe a little less. And the goal is to talk about the claim. And in this case, it's a real claim from a real customer. And a big thank you to that customer for letting me use their claim as an example to help other people learn from what happened to them. And we'll also talk about the denial of the claim, what happened, why it happened, all of that. And then what we're really going to spend the most time on is the appeal, how we wrote up the appeal, what went into it, what was said, the first time around that didn't really help, and what we said the second time around that hopefully will make a difference. And so we'll cover all of that. Also, we'll take a couple of moments aside to just look at one additional example of the same type of thing, but a different situation, just so we have, we can compare. And then also talking about a little bit about integrating doctor's notes into your notes to kind of make a cohesive argument, and also a way to show some trends, hopefully just a helpful tip of how to show trends in patient info in a way that is easy to read and understand. So that's where we're going with this today. Okay, so let's look at the claim. This claim was interesting because the practitioner in this case sent over 100 pages of documentation. It was actually about 120 pages. That included doctor's notes, hospital notes, notes from different surgeries the person had had, podiatry notes, wound care, therapy, prosthetist notes, everything. So that is a lot of documentation. That's actually kind of too much unless it's explained. And when we went through this documentation, there was actually quite a bit that really didn't pertain to the prosthesis itself. So, if you have 120 pages and it's all totally relevant, then fine. But it would be pretty surprising to have that much documentation that's relevant to the care of the patient from a prosthetics standpoint. So it was great. They had a lot of documentation, but it maybe wasn't, all usable. The next thing that went in with the claim were typed practitioner notes. So that's a huge one. I just wanted to highlight that because I wanted to point out that if you are still handwriting your notes, you're really hurting yourself before you even send the claim through for processing. The bottom line is Medicare says this in many different trainings and many different places on their website, and then if you do any of their online webinars, that kind of thing, they always mention this. But the bottom line is if they can't read any documentation you send in, then they're not going to use it as part of the determination for coverage or not. So if you're turning in handwritten notes, even if you have great handwriting, which would be pretty rare from my experience, so even if you have this fabulous handwriting, it's probably not legible enough that they're going to work through it and try to find the answers to the questions they have about the claim. And if you get notes from an outside provider like a therapist or a doctor that are handwritten, consider typing the pertinent parts. What you don't want to do is highlight or point out any parts in those notes, because that could obscure the data. And if it's obscured even the slightest bit, they just won't look at it. So what is often a good idea is if you get handwritten notes from a doctor or therapist, when you type your cover letter or when you make a response to Medicare for their ADR or whatever, their additional documentation request or whatever you're doing, mention in there, here are the notes that are relevant. I've typed them out so you can read them. And then I'm also including the handwritten version so you can verify it, so that, they are not having to do the work of trying to figure out what the handwriting is, what it means. Also, jargon and abbreviations are just never a good idea for a note. So I just wanted to highlight that. This claim also had a letter of medical necessity. And if you recall, it wasn't too long ago that a letter of medical necessity was a really valuable thing to have, and really was a good way to show that the doctor was on board with the treatment plan and all of that. Now it just doesn't have as much weight. So while still valuable, still may have good information, you're still going to need doctors' actual chart notes to back up whatever the letter of medical necessity says. So if all you have is a letter of medical necessity from the doctor, it's probably not going to be enough. You really need to also have the chart notes to support that. And then the K2 level componentry was interesting to me on this case. The total for this prosthesis was $12,000. And and I didn't mention the prosthesis is actually a trans tibial prosthesis. The person lost their leg due to secondary to diabetes, ulceration, and a long course of wound care and, cutting off a toe, cutting off part of a, ray, and et cetera, and just working their way up, finally leading to that transtibial amputation. And that was a year-long battle trying to save that leg with, wound care and minor foot surgeries. So this was a K2 level prosthesis componentry-wise, although the patient was actually K3 level user. To start off with, they really didn't need a lot of high-end components for this gentleman. So you're looking at, the 5972 being the flexible keel foot, the 5986 being a multi-axial rotation unit. So together, that's a fairly inexpensive foot. It's not super high-end components here. And then the flexible inner socket with rigid frame, that's $1,100. And then you have like $1,900 for the locking liners. So those are pretty standard codes, pretty average costs. I just wanted to highlight that those were kind of the most expensive codes on the claim. Again, those aren't all the codes, but those are some of the more expensive. And the point being that Medicare is not just looking at and scrutinizing K3 claims. Everybody says, oh, well, I just, am leery of using higher end componentry or K3 componentry. But the fact is that they're looking at all the components and they're looking at all of prosthetics, and K2 is not excluded from that. So I just thought this was a good example of a patient who had, not super fancy components, but still got reviewed just like any other prosthetic claim is subject to. And then also this claim had photographs with it. So there was a photograph of the patient standing in the prosthesis and one of the healed, ready for prosthetic use residual limbs. So we'll talk about when to use those photographs and what they were good for in this case as we go forward. So now we'll look at the denial, what happened with the denial. So the claim was sent in, all that, with the standard codes and what have you. The practice then received an ADR, an additional documentation request. They then sent in the 120 pages we talked about in the last slide, and then got back a little ways later a denial saying that there is no medical necessity, no corroboration in the medical record for the prosthesis, and there wasn't enough documentation sent. So it's kind of bizarre to hear, there isn't enough documentation sent over because after sending 120 pages, kind of odd. But again, is that 120 pages that have useful information, or is it just gobs and reams of paperwork? So we often hear that, well, send everything you have, more is better. And I think this is an interesting case because in this instance, more wasn't necessarily better. It has to be relevant to, and it has to be explained. So that was the denial they got, kind of that generic no medical necessity and no corroboration in the medical record was the general denial. And then right now, just to give you the status, this is a very, very recent case, so it is currently in appeal. So let's talk about, some detail about what we put together for this appeal. What we're going to do is just basically follow the LCD. So we're going to, what my process is when I get a set of documentation from a practitioner is I just read all the documentation. So you can imagine at 120 some pages, it took me a little while to get through it all, but that really should be everyone's first step, is not just to receive a bunch of paperwork and send it through, but you really need to look through that paperwork and see what exactly you have there and what's useful and what isn't. So my first step was to read through it all. And the next step is to have the LCD right next to me, the local coverage determination. This was a Medicare case this time. So I have the local coverage determination sitting there, and I'm just going to go right down that local coverage determination and check off each section. So the first thing being, that first part of the LCD, will the patient reach a certain functional level in a reasonable amount of time? Then I'm going to go back through that documentation. I'm going to find whatever's in that documentation to support that, yes, that person will actually reach that functional level that we've put them at in a reasonable amount of time. So in this case, the patient was definitely a K3 level ambulator. There's really no question about that. It was clear, that the person has that potential. And but now we have to go and find the supporting documentation for that. So the first thing was to go through the therapist notes in this case. And the therapist notes were really interesting in this one because they actually started out, firstly, loaded with jargon, loaded with abbreviations. It was really hard to sort of weed through all these abbreviations and all this jargon and figure out what everything meant. So that's, problem one. If you're sending that into the reviewer and it's not clear what all these things mean, then you can't know that it's going to be clear to that reviewer either. So first thing was to sort of figure out what the therapist was trying to get across. And I'm reading through and it says the patient is expected to be at a CK level or is at a CK level and expected to move to a CJ level in 3 months. And I'm thinking, what the heck is a CK and a CJ? I've never even heard of this. So I go through, I spend an hour and a half online trying to figure out what the heck these C things are. And I just want to throw out there that that's what code is for. That's one of the many purposes of the code program from SPS, is that if you get back a bunch of notes and you're looking through those therapist notes thinking, I don't know what these abbreviations are, I don't know what this jargon is, you don't have to spend time looking that up. You can send that over to me and say, could you please figure out what this therapist is trying to say and translate this for me and send it back? And that's what I'll do for you. So that's just a little something to throw in there that, let me do those time-consuming things so that you can, be with your patients and do more work, in your own clinic. So bottom line is I spent the time online, figured out what it was, and it turns out there was a fairly recent mandate from CMS to therapists. And without going into a ton of detail, I have the detail. If you want it, please contact me and I'm happy to share with you all the nitty-gritty on this. But without going into too much detail here, it's basically a label for severity and for where the person is with impairment. And they look at impairment at different parts, in different parts of the person's life. So the mobility impairment was the thing we really wanted to focus on and look at. If you see here, it says, what do the levels mean? So CH through CN are the levels. If the person is a CN, if the patient is at CN level of impairment, in this case, again, looking at mobility impairment, that would mean they're 100% mobility all the way up to 0% impaired in mobility in this case at the CH level. So where our patient is for this case that we're talking about in this webinar is they came in, they were assessed by the therapist at a 40 to 59% mobility impaired level. So the therapist said, after looking at this patient, after doing an assessment, I've figured out that the person is 40 to 59% impaired in their mobility. And after doing a bunch of therapy for 3 months, I think that the patient will actually end up at a CJ level, which would be the 20 to 39% impaired. So this therapist felt like after 3 months of therapy and use of a prosthesis and whatever other tools the person has at their disposal, they will end up being only 20 to 39% impaired. So definitely improving, and that's a good thing. But again, if you're reading through those therapist notes and you haven't heard of these C levels before, and they are newer, so it'd be understandable if you haven't seen them before, it would be pretty confusing. Now, we hope that the Medicare reviewer already knows what these C levels are, but whether they're going to, correlate that with the use of the prosthesis, we don't know. So we want to make sure that we're drawing that connection for that reviewer and saying, look, the therapist thinks this person is going to get better. This person isn't going to get better just, sitting in a wheelchair. It takes a prosthesis and therapy. And those are the connections you want to try to make with your appeal. The next thing we're going to look at is, again, just following right down the LCD, does the patient have a motivation to ambulate? Do they have the desire to ambulate? Again, I'm just, using the LCD as a guide, saying, what is the reviewer looking for? What does the reviewer need to see in these notes? And what they're looking for is what's in the LCD. So the next thing in the LCD is that motivation and desire to ambulate. So we're going to look through these notes and find something that supports that. From the therapist, we have a statement in the therapist notes that says that the person had a goal, this patient had a goal of being able to walk normally again. And that was in the therapist notes. So that's good corroboration for us to say, we're telling you that this person has a motivation and desire to ambulate. And then look, here in the therapist notes, you'll see that the therapist also, noted the person did have a motivation and desire to ambulate. It was one of the person's goals. So let me stop right there and say, let's back up and think, wow, would that reviewer find that statement, this one quick line in 120 pages of documentation? I would be skeptical that reviewer would happen to run into this line through, looking through 120 pages of documentation. It could happen for sure. But I would like to make it as easy as possible for this reviewer to find the information they're looking for. And if that means saying, here's a cover letter that says, and you see in your handout there's a cover letter that says, under motivation and desire to ambulate, yes, the person has a desire to ambulate and the motivation to do so. Note that in the therapist note from this date, in the section under plan or under goals, whatever, that the therapist states the patient had a goal of being able to walk normally again. And, so we're making a roadmap for that reviewer. We're saying, here's the information, but let me tell you exactly where you're going to find it in this big stack of notes. So we don't want that reviewer to have to work too hard. We want to, make sure they find the information they're looking for as easily as possible. The other thing we find for support in this case is the satisfaction survey from the prosthetist office. So one of those pieces of documentation that was sent in was a satisfaction survey shortly after delivery of the prosthesis, and the patient writes that the prosthesis has given him his life back, as a quote. So again, we're going to say to the reviewer, note also the patient's motivation as shown by the statement in the satisfaction survey, page whatever of the documentation I've included here, where the patient states they've given me my life back. So, and then here's one place we could use photographs. So the patient is shown in one of the photographs standing independently with the prosthesis on. So what you wouldn't want to do is just toss those photographs in there and hope the reviewer puts it all together and says, oh, okay, they're trying to show me that the person really can stand or use the prosthesis or has worn it. What we want to do is say, here's another thing to support the motivation and desire to ambulate. Note that you'll find in the documentation, page whatever, a picture of the patient actually standing and utilizing the prosthesis. And he was able to don that prosthesis independently. So I've said this before in other webinars and other videos and what have you, but what I just want to highlight again is that you don't want to ignore the other medical problems that the person has. You want to highlight, yes, you understand the person has some medical issues, but let's explain to you why those aren't going to be an issue moving forward with rehabilitation or for use of the prosthesis. But focusing on the beneficiary's past history, in this case, the prosthetist notes actually had some really good information about the recent past history of the patient. So again, in supporting the idea that this patient is actually a K3 level ambulator, we want to be able to say that recently, in the recent past, this person had good physical health. And in the prosthetist notes, it stated that this patient worked construction. And that was only 12 months ago when the patient actually was a little ways into the wound care treatment, that he stopped working in construction. But up until that time, he had worked construction for over 20 years, I believe is what it said. And so for many, many years, worked construction, was very physically healthy. And this isn't like construction management. This was on the ground, doing the work, digging the ditch kind of work in construction. So he was physically healthy enough to do that just 12 months ago. Along the lines of indication of the need to walk and his motivation and his recent past history. He has 3 children at home. During the course of this treatment, of all the wound care treatment, his wife ended up having to go back to work full time. So now in his situation, he not only was helping with the children in his recent past history, but now he will need to take care of the children since his wife returned to full-time work. So that's something to highlight, that functionally this prosthesis is very relevant and needed because he has the functional need of taking care of 3 kids. And these are young kids. So that's just something that you'd want to highlight again to that reviewer. Now, I will say too that all of this information was in the prosthetist notes. Notice that the reason we're telling you this person worked construction and has 3 kids at home is to highlight the fact that he has been healthy in the recent past and he has a functional need to start ambulating again and using a prosthesis. So those are kind of the things that we want to make that link for the reviewer. And then another thing is his current condition, other medical problems. His suture line is fully healed. Here's the other picture. Again, this picture was just submitted without any explanation, but ideally you would have an explanation in the cover letter when you're responding to the additional documentation request that says, note, we've sent a picture, page whatever, page 10, in the appeal packet here, that shows a fully healed suture line. The patient's residual limb is ready to go ahead and begin using a prosthesis. So those are the things from a prosthetist notes that explain why the person's a K3 level ambulator, what their current condition is or medical problems and past history that kind of lead us to the fact that he is a K3 ambulator. Following along the same along the same train of thought, we're also going to look at what doctor's notes we have that explain the beneficiary's recent past history, the current condition, and the other medical problems. So looking through all the doctor's notes that were submitted, we find some information that either needs to be explained or supports the patient being a K3 level ambulator and needing a prosthesis. So in the doctor's notes, what was listed was that the patient had ulcers on his feet. So that's something that we'd want to highlight and say, yes, the patient's had past issues with skin condition and has had past breakdown of skin. But those are under treatment. He's seeing a podiatrist for that, etc. So you want to kind of explain that. And don't let that hang out there. Again, if all the reviewer is getting is a bunch of documentation from the doctor that says this person has all kinds of ulcerations on their feet, but they're not getting anything that says, but don't worry, we're healing those up, or these are the steps we're taking to make it better, then that could be a red flag for them to say, how could this person be a K3 if they're having all these ulcers and problems with that? Also in the doctor's notes, it states that the patient had undergone anesthesia several times for several different surgeries. And that's just something you could pull. I just wanted to throw it in there as an example to say, look, you have to be at a certain level of health before they're going to actually put you under general anesthesia. So obviously this patient was healthy enough to undergo general anesthesia in the very recent past. We also found in the doctor's notes, or I also found in the doctor's notes that many times over this 12-month course of wound care and minor foot surgeries, the patient was required to be non-weight bearing. So you've all seen this in your practices. The patient is going through this wound care thing, trying to save the leg, whatever, seeing a podiatrist all the time. And every time they do some surgery or do a major debridement or anything like that, they'll say, oh, stay off your feet for a while. Wait till that heals up. Don't go anywhere. So this was something that was in the notes several times. And we want to be able to say, yes, the person was actually required to be non-weight bearing for multiple for a long time during that previous course of treatment. That's one of the reasons he's debilitated now. So again, if you put your reviewer hat on and you're looking through and you're saying, gosh, this guy's so debilitated, he's clearly just a K2 level ambulator. We want to say, wait, Mr. or Mrs. Reviewer, he is a K2 level ambulator right now, but that's partially just because he was, on his backside for so long. He was required to be unweighted or non-weight bearing for so long during this course of treatment. So yes, he became debilitated, but if you look at his recent past, and his needs, his functional needs going forward, he actually will be a K3 level ambulator. He's been at that level before. He has the need to be at that level again. So, even though the person is debilitated, we still expect them to get over that, right? Keep in mind that the orders that the doctor writes are not considered part of the medical record, but it is supporting documentation. It is something you could highlight to the reviewer, and we would just want to make sure we also have the information from the medical record, meaning the doctor's notes. So what would we like to have in these notes? Over here on the right-hand side of this slide, you'll see additional info. And this is what this is what would be nice to have had in that 120 pages of documentation. So again, a lot of documentation, but what we didn't have were some really key things that would have been helpful. And it's probably out there. It's probably in the doctor's notes. We just have to get the right doctor's notes. And what would be ideal would be to have a primary care note regarding the medical management of this patient's hypertension. In this 120 pages, it was noted several times from hospital admissions and therapists and all this that the patient does have a history of high blood pressure. So we want to say, yes, the patient has a history of high blood pressure, but that won't limit his ambulation because, as you can see in Dr. Whatever's note from this date, he is under medical management for the high blood pressure and on medication or what have you, and it's controlled. What would also have been nice to have is a primary care note recommending exercise or weight loss. Often you can find in a primary care note that's just a regular wellness visit or a regular checkup where the doctor will say the patient has a BMI of whatever, encourage the patient to consider exercise and change of diet to control or to lose weight or whatever. Often those wellness visits will say just a quick one-liner about that, and that could be information that we could use to support the prosthesis. He's certainly not going to lose weight sitting around in a wheelchair, but if the doctor wants him to lose weight, a prosthesis could contribute to that and help in that endeavor. So there was some good information in the therapist notes that actually can be used as a support for the prosthesis. One thing the therapist mentioned, this patient, again, because of this long course of wound care, had been using a wheelchair. And that even with a very short time of using the wheelchair, the patient had experienced significant shoulder pain. So that right there, if just left in the notes without any explanation, you wouldn't expect the reviewer to say, oh, see that? The shoulder pain with wheelchair use, that means he would do better with a prosthesis because, he's obviously not a great candidate for a wheelchair if he's already got severe or significant shoulder pain with just a few weeks of wheelchair use. Also, the therapist noted that the patient had a high body mass index or BMI, and that was due to that period of decreased activity. So the patient wasn't necessarily overweight or obese before all of this wound care treatment and this limb salvage had started. But during that course of treatment, being sedentary, getting generally debilitated, caused him to gain weight. So again, we could say, look, the prosthesis can contribute to this person losing weight by helping him get out and about, by helping him, walk more, be more mobile, etc. And you want to make that connection for them. Now, there were some things in the therapist notes that were actually seemed to be a little detrimental. But again, your options here are to give Medicare the therapist notes and a good explanation of what it all means in relation to the prosthesis, or your other option is to give Medicare the therapist notes with no explanation at all and let them draw their own conclusion. And guaranteed they're not going to draw a conclusion that's going to be supportive of a prosthesis, probably. I guess it's not a guarantee, but often they're going to, find that, oh no, it turns out the patient isn't a K3, they're K2 level ambulator or what have you. So we just want to explain what is contained in those notes. And in this case, the therapist actually had this patient do the tug, which is the timed up and go test. If you're not familiar with that one or don't remember it, it's where the patient's sitting in the chair. They stand up, walk forward about 20 to 30 feet, go around a cone, come back and sit down again. So it's a very quick, simple test. And those scores have been correlated to different things. There have been studies that say people with amputation generally score higher than the general population. In this case, I just wanted to show, just as a general idea to get you in the mindset of how good or bad 34 seconds is for this patient. So 34 seconds is how long it took this patient to complete the tug. Again, that's getting up, walking around a cone, sitting back down. That's a pretty long time, and he used a rolling walker to do it. And this was right after he'd gotten his prosthesis. So if we do want to make a general comparison, again, this is just for your own knowledge, look at what the scores would be generally for an 80 to 99-year-old person. So this is a person with no other issues except being very elderly, 80 to 99 years old. That person who isn't an amputee, has no other issues, would have done this in 11.3 seconds. He is 41 years old. 41 years old. That's not very old, right? And so if you're thinking about, okay, this guy's 41 years old, he's got a transtibial amputation, so it's pretty low level amputation. How is it possible that he scores 34 seconds? And so what you would want to do is not let that reviewer see that and say, gosh, this guy is really debilitated, he's in bad shape. We want to say, yeah, right now he scores 34 seconds, which is generally a pretty bad score, even for someone with an amputation. This is very soon after his amputation. He just started rehab. He's learning to use that prosthesis. It's new to him. And he, again, has been very debilitated through this course of treatment. He needs to overall be more fit. So all of that is just to say that you want to, again, make the connection for the reviewer. But keep in mind that that doesn't mean this person doesn't have potential for K3 ambulation. He absolutely is a K3 ambulator after he gets through his rehabilitation. So just to wrap that all together, we want to highlight for that reviewer, again, the cause of this person's current K2 level, right? And that's part of the LCD. It says if the person is at a certain level now, but expected to be at a different level later, explain to us why that is. And that's what all that information was. And again, why do we expect him to be a K3 level now? So that's why he was a K2 at this point. But remember, there's a previous activity level. He was in construction work. It's a physically demanding job. He was in good enough shape to do that prior to all this wound care treatment. He also is expected to be a K3 level ambulator because he has home maintenance and independent living to get back to. He's going to have to kneel and bend and get in confined areas. He takes care of his home. He repairs plumbing, mows the lawn, maintains the pool, whatever it is he does, right? You want to add that in there, get really specific. And then again, we mentioned before, he has childcare activities now. He's got 3 young children at home. He needs to be able to get those kids to their activities. That's going to require walking on uneven ground. He has to be able to keep them safe, which means keeping up with them physically, which means changing cadence. And you also want to point out, and I want to highlight here, the frequency of these activities. So you don't want to just say that he's going to take care of the kids and that he does home maintenance. You want to say he does, he maintains his home, means he mows the lawn every week or every other week for an hour at a time. With the child care, he takes care of the kids every day for 6 hours a day, whatever it is. And so just it really helps you in general to be really clear about the frequency of all this activity. Don't just say he walks on uneven ground. He walks on uneven ground to do this activity, and he does it this often. Part of the LCD talks about, and the K3 level is utilization beyond simple locomotion. That's a key component of being at a K3 level of of functionality versus a K2. So really hone in on that and say, what is it that he is going to use this prosthesis for besides getting from point A to point B? Well, he's going to have a home therapy program ongoing. So that's utilization beyond simple locomotion. He has stretching, strengthening he's going to do. He also plans to do some weight loss activities that his doctor and therapist urging. So for him, that means he's going to walk 2 times a week just for exercise. That's beyond simple locomotion. He's also going to do meal preparation. He's going to do ADLs. He's going to, take care of himself in the bathroom and deal with everything in the kitchen. That's standing in one place for a long time, moving backwards, side to side in a confined area. All of those things are utilization beyond simple locomotion. So just taking a step back here, note that the slide has blue on the top and the bottom now. That's just to highlight that we're going to pause for a moment in that appeal that we've been talking about, that claim that we've been talking about as an example, just to throw in another example, just, so that you can see, in a different circumstance, how would we do this for someone in a different situation, but similar. And so this patient had a recent amputation surgery. He did use a wheelchair after the surgery. And then after the surgery was completed, he had several heart and gastrointestinal complications. So that prolonged his rehab time and actually caused him to become more debilitated after the amputation and to stay in a wheelchair even longer. So that was all in the doctor's notes too. Also, prior to the amputation, this patient had asthma and COPD. And so, again, putting on your reviewer hat, you are the reviewer and you're seeing this person has had a recent amputation. due to diabetes, actually, in this case, and is using a wheelchair, and has had heart and GI complications, and has had and does still have asthma and COPD. Now, I'm coming in as the prosthetist and going to tell you, Mr. or Mrs. Reviewer, that this person is going to be a K3 level ambulator. Well, it's sure not looking good for that right now, right? So again, let's highlight what it is. Let's explain to that reviewer in no uncertain terms why we believe that this person is going to be a K3 level ambulator. And then let's use some doctors and therapist notes to back us up on that opinion, right? So in this case, yes, the patient did have heart and GI complications after surgery. So the doctor said, yeah, the person had heart and GI complications. We've addressed that. He's on medication. He's okay in that respect. The heart and GI complications did cause this person to be debilitated. Now that they're under control, we fully expect this person to get back to the previous level of function that he was at, which was a K3 level. And then we're also going to focus on this person's previous activity. Why do we think he's a K3? Well, because prior to his amputation and dealing with the heart and GI complications, he was working full time. He was caring for his live-in mother, elderly mother. He spent time with his grandchildren every month, and he was golfing and walking the course during that time. So again, we're making the connection for the reviewer. And then what's his post-rehab activity? Now that he is a little bit debilitated, he's recovering from this amputation surgery and all these complications, what's the plan? Well, he's seeing a physical therapist. He's got a home PT program that he's going to implement, and he's going to return to his previous activities. And in this case, the prosthetist did have a statement from the patient saying that he plans to go back to work, to caring for his mother, and getting back to golfing. Those are his goals. So there you go. It's, we've again pointed out to that reviewer, here's the information, and this is why it's relevant to the prosthesis. This is why it supports our choice of K3 for this person as opposed to K2. But again, before we go back to our original claim that we started talking about at the very beginning of this webinar, let me just quickly talk about a charting technique that you might find helpful, kind of a quick tip on the side, and it's relevant to these claims. Let's say that, so what we do right now, at least what the code program helps people with, is responding to those ADRs, responding to those additional documentation requests, and with the mindset that the information needs to be explained, right? And so we create a cover letter that goes with all the additional documentation that you send in. And the cover letter kind of links all those notes together. The doctor's notes, the therapist notes, and the practitioner notes are linked together in this cover letter. But that's not necessarily the ideal way. It's good. We want to keep doing that. We want to link that up. But in a perfect world, those connections would already be made in your chart notes. So ideally, you will have taken the information from the doctor and the therapist and put it into your regular chart note that you write every time you see the patient. And when the ADR comes through, you just take the notes you've already got ready to go and send it in, and it's all linked together. And you don't have to go through this process of doing the linking afterwards. So again, code is here to help you with those charts that maybe don't have all those connections laid out very clearly. But going forward, a technique that you could try using is to link those documents ahead of time. So just as an example, if you have the patient come in for the evaluation, right? After the evaluation, you're going to request the doctor's notes. And what you would ideally do is, instead of just getting those doctor's notes and putting it in the patient's file for later, you would actually review those doctor's notes and pull out information that, one, you need to either address. So is there anything in there that is a complication that might indicate the person is not at a certain K level that you think they could be at? Or the other thing might be that you find support for the prosthesis in those notes, and you want to, highlight that as well. And when I say highlight, I mean mention it in your notes. Don't physically highlight it. But so what you would do is review those notes. Then the next time the patient comes in for their casting, say, you do your regular casting note. You see the patient do the casting, make the note, and then at the end of that note, you would add a description and interpretation of the doctor's notes that you received prior to this visit. So you would be saying, okay, saw the patient today, cast them for this is how it went, everything was great. Also, on this date, we received doctor's notes from Dr. Whatever. It is noted in those notes that the patient has COPD. The reason this is not expected to be an issue or affect this patient's ambulation is because it's a long-standing issue for this patient, and it's under medical treatment and has not restricted this person's mobility in the past. So we don't expect it to be a problem. Likewise, if the note says that the patient would benefit from a prosthesis, or that the doctor feels the patient should be evaluated for a prosthesis, you would say, also noted from these doctor's notes that the doctor requests the patient be seen for a prosthesis, and etc. And link this all up, right? So you would do that right there in your charting note, and then, or in your casting note, in your chart note for casting. And then again, you're building the case as you go, instead of having to take the information and put the case together after the fact. Then say the next time the patient comes in is their check socket fitting. You do your standard note, fit the check socket, everything went fine, did the alignment, whatever, and then add to that what you got from, say, the therapist. So after that last visit, you requested therapist notes or whatever other provider they saw. By the time you get to the delivery note and the delivery appointment, a nice way to wrap that up is to request that once the patient has worn the prosthesis for a day or two, they could write a letter explaining how they use the prosthesis every day, what it does for him or her, why they feel it's an important thing for them to use, and how often they use it, whatever. And make sure that's in that patient's own words. So again, this is just kind of saying, look, the prosthesis will help maintain the residual limb, whereas let's say you put him in a wheelchair or have him not use a prosthesis and he's stuck in a wheelchair, he's going to have issues with residual limb health. We know that when the residual limb just hangs down off the wheelchair, especially someone who has a problem with peripheral vascular disease already, those people are really at risk for severe swelling, for pitting edema. One thing in this patient's case that was a positive is that in the very short time that he actually wore the prosthesis, so he had worn a check socket for a week or so and then took delivery of the prosthesis, wore that for a little while, you could see that the overall size of the residual limb reduced very quickly. And that's something that was really good to point out, that look, not only is the prosthesis beneficial for mobility, but you can see that it's actually decreasing the swelling in the residual limb, and better than the shrinker did. So what we don't have here that would be helpful would be measurements of the patient from the very first visit all the way through to the very last visit, and that way we could compare just the measurements from using just a shrinker all the way through to use of the prosthesis. We don't have that in this case. That would be nice to have, just future reference, but we still have some really useful data in this chart. Again, this is kind of a side note, but it's related to this particular appeal. How would you highlight to the reviewer that to see that trend in the patient's residual limb size? Often we'll have a bunch of measurements on a measurement chart or a measurement sheet that we took at different dates, and you can see here you have 3 different dates where the patient was measured. And then overall, you'll see the average circumference went down overall, right? But when you have it in this format, it can be a little tricky to read, right? You can see a trend, it's clear, and you could point that out in your notes that the trend is there, but wouldn't it be even more powerful if you had something more visually clear? So instead of this reviewer saying, okay, I see on this date he's at this size, on this date he's at that size, and if I do the math, I end up with a smaller circumference. I mean, we don't probably think the reviewer is going to do all that. As a, hey, here's a cool trick you could try kind of thing, notice that same data is now shown here in a chart. Really simple to do charts. And this, please believe me, I hate Excel probably more than the next guy. I really hate it. It's really hard for me. I don't enjoy using it. I know people out there, some of them are just like Excel crazy, and that's great for them. That's not me. But what I do find easy and very helpful is entering these data points into Excel from the measurement chart and coming up with these pretty little graphs. It's actually fairly easy to do. It's really quick. And again, it's so much easier to see a trend. It's easier to point out to the reviewer the benefit of this prosthesis and how it helps residual limb health by reducing circumference in this format, where the reviewer can say, wow, over time, the trend is that the circumference is going down. It was pretty clear from this chart, quick and easy, and it's more powerful. If you have information that you've gathered over many visits with a patient, whether that be height, weight, average circumference, or even if you don't have average circumference, any circumference measurements over time, or if you have, if you took a survey several times for that patient and you have that information, you could send that all to me. I will compile it into a graph and do this for you. If Excel is your worst enemy, which is totally understandable, or you just don't want to take the time or can't take the time, you send it to me. I'll make you the little chart and send it back to you for you to use as part of your appeal process, as part of your regular chart note, whatever. You could also set up charts. Those of you who have children know that when you go to the pediatrician, every time they take a circumference of their head, especially as an infant, every time they take height and weight, they note it on a little chart in the actual patient chart. And all they have to do is put a little dot. And then over time, you see this trend. The baby's trending up, the baby's trending neutral, or the baby's trending down. And it really gives you a powerful idea of if this kid is getting good, getting better, staying the same, or getting worse. And you can do that same kind of powerful stuff with prostheses and orthoses, depending on what information you track. Before we wrap this up, I wanted to bring up a question that was asked during the live webinar and give the answer to that, because I think it's a question that I've gotten a lot and a question maybe a lot of people have about outcome measures. And I want to be very clear here. This is my opinion based on what I've seen working with people across the country and their documentation. But the question was whether or not to use outcome measures or outcomes measures in your clinic as a P&O provider. And in my opinion, the answer would be if you already have excellent doctor's notes and therapist notes, and your notes are fully in compliance and they're just spectacular, then using outcomes measures is the next logical step. It's going to elevate your practice, it's going to help you make clinical decisions. It helps provide a clear way to explain your clinical decisions to everyone who is involved in the process. So it's a really good option. However, I think lots of practices just aren't there yet. So if your notes are not fully compliant, your doctors and your therapists don't write appropriate notes for you as a general rule and don't know what to write, then I believe your time is better spent in educating doctors, therapists, and patients on what's required for your notes and on what your orthosis or prosthesis does for the patient's overall health and well-being, versus you taking that same amount of time to learn how to choose, use, and interpret an outcome measure. So again, there's a learning curve with outcome measures. They take some time to implement, learn, and figure out, so it slows you down a little. If you're going to take time out of your practice to learn something new to help your documentation, I would say your best option again, is to get your notes in compliance and get your doctors and therapists on board. And so while outcome measures are really important and we do want to use them, it's maybe less urgent than other documentation improvements that need to happen for most people. That's our whole case. And again, we're in appeal, so we're waiting to hear the answer on that one. If anybody's curious about how it turned out, I will probably tweet the results later when we find out. So I also just want to thank SPS for supporting this program. Again, Code is a service that SPS provides for their customers to help your business be more successful. And also, if you have questions about this webinar, if you have comments, if you have feedback, love to get any of those. So please do email me. You can email me at code@spsco.com. You can also give a ring if you dial the regular SPS number 800-767-7776 and dial extension 5. That will ring straight to my cell phone. And so you'll get me directly. If you have to leave a message, I will call you back quickly. So that is that extension 5 is a direct line to me in my office. Please do submit any questions, any feedback, ideas for future webinars. That's all great for us to know, ways that we can improve. We'd love to hear that. So thank you very much, and look in the future to get emails from us about upcoming webinars soon. Actually, one every month until the end of the year. Thanks.